Thank you. Yeah, I'm the drug and alcohol and smoke-free lead in Berkshire Healthcare, and I've been in post for about 4 years. And the first year was really spent trying to get vaping introduced into the hospital at the point of at the beginning when we didn't have any. I have it here. Yeah. So we all know, and I'm talking to the converted really when I speak about why smoke-free is a priority, and we've already gone through that. But of course, extra to that is the inpatient setting itself and the time that we've got and the time that we can use to teach other people different coping strategies as well and ensure that they get plenty of behavioural support and a very flexible service when people are, if you like, well, they're there, aren't they, for sometimes anything from a week to up to a year's stay. So we've got a lot of scope within mental health wards to be implementing our tobacco dependency service. And the review from MHARG talked about the place and requiring to roll out the service and fully implement that service to make sure that we're working alongside the operational policies, that we're able to provide the treatment and nice guidelines around that, and that's where the vaping came in, because at that point we weren't, and then looking at staff attitudes and behaviours, which, as we've said before, can be quite tricky, especially within mental health services, because we have had a long and complex relationship within mental health services, mental health nurses and mental health patients in the past. So our own trust does our own QMIS, we use our quality improvement tools, and we started looking as part of our inpatient steering group at how come it was so bloody difficult to implement smoke-free, basically. And it felt that we were just smoke-free in name only, and, you know, okay, it says it on the signs, but I can smell it everywhere, people are smoking, yeah? And we used the fishbone tool as part of our QMIS tools, and, you know, looking at the patient factors, where we identified, you know, it's an addiction, and maybe we need to change the terminology and stop thinking about you know, as a right. Actually, it's an addiction. It's not a lifestyle choice. The fact that people felt, well, patients are in crisis, I think, has already been mentioned. We weren't really working that well with replacement therapy. Some people, it was a bit ad hoc. Sometimes even the medics weren't too sure about prescriptions and how available it could be. They didn't like HRT, some patients, their previous experience of it wasn't the best. And we were having a real incident, prevalence of high kind of impact incidences on the ward between patients and staff. There was things, you know, bringing in lighters, trying to smoke in enclosed gardens, enclosed bedrooms. There was actual verbal assault, there was actual assault. So there was a lot going on the wards. And we also thought about the staff and the inconsistencies in the approach that we were doing. Our wards, there's 4 acute wards, we have a PQ, we have 2 elderly wards, and people were doing different things, which was really confusing staff and patients. Some of them just didn't agree with the smoke-free policy, basically, and were quite vocal about that. And we've mentioned about misconceptions around the treatment. And then we looked at the task factors, leave to smoke, it wasn't really a priority for people, and communication where patients weren't aware that they couldn't smoke, so that caused friction when they came into the wards, told different things from one person to another. It's good to vape, it's not good to vape, you know, you can have NRT and vape, you can't have both. And Section 17 leave being used, you know, to facilitate smoking, which we know from the reports before. And we didn't have very much training, you know. There was 1 hour that was just part of a physical health training, and that was kind of it. And it wasn't essential particularly, and we couldn't get it mandatory. So, and, you know, the working conditions, people were saying, well, it's a really stressful environment. You know, we've talked about loss of rights before. And if we stop smoking, it's going to increase the volatility on the ward, and these were the kind of misconceptions and attitudes that people were having. So our patients were saying things like, we're not ready to stop, we don't like the device that you're giving us, that was the e-burn at the time, it doesn't satisfy us, I'll stop when they've stopped because they can smell, staff are smoking, you can't stop me when I go and leave, I vape at home but you're not letting me bring it here, so I'll go and I'll smoke my own. But they let me store my tobacco in the other ward, why are you not allowing me to do it here? It helps me with stress. I'm sure all of these things are things that you're all familiar with. And our staff doubters were saying things like, well, this is the worst time to ask someone to stop. They've just come in against their will, stress relieving, vapes are just as bad as smoking. And for themselves, they felt it helped them to stop and pause and think and give them time out of the ward. If they were smokers, they didn't get that opportunity. So what we did, well, we put in our business case for our fantastic tobacco advisor. She's here today since last June. We listened to our patients about the device and what they wanted and why they were, trying to smuggle in lighters and smokers. What was it? What was it about our policy that they were finding difficult? And they basically told us our device was rubbish. And if we were to use something that, they used at home, then it would make it easier. So they gave us top 5 kind of popular consumer products, and we went with those, and then we worked out which one they liked most. The CQC were telling us, store tobacco, give it back when they're going on leave, and we decided to go against that, and we stopped storing it. We're not quite at the fact where we can dispose of it yet, but that's something we'd really like to be able to do. If you bring it in, you won't get it back, but at the moment that still happens, but not for leave. We had live events throughout the trust to endorse the message, and we had the executive team bring it up quite frequently in their monthly exec meetings for all the staff, which was really useful. We re-established the trust-wide steering group. Marcom's kind of drip-fed messages around some of misconceptions, what you were able to bring in, what you weren't. We did use the national events to support the agenda on social media. We did TikToks, we did Twitter, we did you name it. We engaged our hospital staff in a staff focus group, which is another story because it's been quite successful. We've managed to get the VBA training essential now, and that's delivered by the local authority, which is really good, partnership working. And we've got MEC training, again, that's now essential for all staff, and that's supported for across our mental health teams, both community and inpatients. We're improved the pathway with our local authority, smoke-free colleagues. We got involved with carers and families and asked them, if you want to bring in something, you can bring in a vape, really, because that was a huge message. Because we were finding that families were still bringing in tobacco, and it was causing real difficulties. And we went to our partnership meetings, crisis team meetings, liaison team meetings, and really pushed that pre-admission conversation so that it wasn't going to be a surprise when they got to hospital. And again, it was more of a tango than a waltz with a lot of the clinicians, because a lot of clinicians thought, it's the wrong time and didn't really agree with the policy. So the big thing that we have seen straight away is the reduction in those incidents. In the first 6 months of 2022, there was 151 smoking-related incidences. And they, as I said, were behavioural things, conduct, assault, bringing in contraband and lighters, which of course increased fire risk. And then since June, so we've changed our device. We have a tobacco dependence service in-house. It's been reduced by 46%, which is amazing. And a lot of our doubters didn't feel they thought the incidence would be higher, so it's quite useful as a motivational tool. So we still have plenty more to do. Our Marcom's communication continues because we've got smoke-free coming up next October, which is our next thing, where we want to stop that facilitating of patients to smoke and look about how we can implement that, and further endorsing the staff smoke-free policy, which again is loosely adhered to, so there's going to be a lot of work around that 1st October. The ongoing staff offer, which, as I say, we've had one focus group and it's been quite successful, but now there's been more staff very keen to get involved, and they're noticing that they can see the culture change within the hospital, which is really good, and feel, you know, that they want to get on board. We're developing bespoke mental health tobacco dependence training for all the clinical teams, and that's including, you know, those in primary care pathway, and trying to roll that out across so that everyone's informed and talking really the same message. Improving the inpatient and community pathway, reviewing our post-discharge support, because what we're finding is people are doing really well, but then we're finding it difficult to engage them 4 and 6 weeks later. So trying to get our community mental health colleagues involved in that so that they can support us with the feedback and how people are doing, and, you know, encouraging them if they need more support to continue with that. We're involved in the fire training because that's mandatory, and getting some slides and getting our voice heard in there. Rolling out the Making Every Contact Count across, as I said, community teams as well as inpatient. And we actually have been allowed a discussion around having smoke-free and our trust induction, which is the first time, because there's been a no for now, so that's really encouraging as well. And that's the Berkshire Healthcare journey.
Thank you very much, Helen. Really important talk.